organisms vary, it means that your approach to management will most likely vary as well. You can also have otitis externa. Otitis externa usually involves the pinna and the external auditory canal, or it can involve just one or the two structures. In terms of presentation, otitis externa could present as acute localized infection, or it could be an acute diffuse infection. So it's not like you have a part of the pinna involved, but you have a global distribution of the lesions. It could be chronic, or it could be what we call a malignant otitis externa, or the reason why this is particularly important to note is that it tends to occur in diabetic patients, particularly those who have poor control of the blood glucose. Malignant otitis externa can be seen in there. So what gives rise to these conditions? The basic pathophysiology of both sinusitis and otitis media is associated with a dysfunction of either the eustachium, ET, or the sinus ostia. Now, from your anatomy, you know these are passageways through which you can have secretions drained away from the structure. With eustachian tube, you can have drainage of secretions into the oropharynx. With sinus ostia, you can have drainage of mucus secretion from the sinuses through these openings. When you have inflammation following infection, these structures, which are relatively tiny, can become inflamed and result in occlusion. So their primary function of allowing body secretions to pass through is impaired. So that's why we say there is a dysfunction. And the resultant effect is that you're going to have accumulation of body fluids. It could be mucus, it could be fluid in these areas that are served by the openings. In this case, with otitis media, the middle ear. With the sinuses, it's the sinus ostia. So let's look at this in greater detail. With the normal sinus drainage, you can see the green arrows showing how the secretions will flow out, and there is no pooling of body fluids. However, when there is inflammation of the lining of the sinuses and the nasal passages, as depicted on the right side of the diagram, see here you have the normal situation, and you can see that the openings are quite prominent. But here you have inflammation of the lining of the sinuses and the nasal passages. This now, it may involve just one infection of the sinuses may involve more than one sinus, and it could be acute or chronic. So here we're showing the maxillary sinus, right? You can also have involvement of the frontal sinuses at times. Okay, but in this picture is showing us fluid collection in the maxillary sinus. The condition is also referred to as rhinosinusitis because you can have clinical presentation that started off with rhinorrhea, that is, the patient has nasal discharge, then later the patient will complain of heaviness in the face, stuffy nose and things like that. With otitis media, which is essentially infection of the middle ear, it can involve both the middle and the external ear structure, and it could be acute or chronic, as stated earlier. When we talk of acute otitis media, the infection is confined to the middle ear, and it is a common presentation in children. The reason why children are particularly predisposed to developing acute otitis media is because of the structure of the eustachian tube. In children, the eustachian tube is relatively horizontal, whereas in adults, you have a relatively inclined structure. It means in children, it's possible for organisms colonizing the oral pharynx and for fluid in this area to drain into the middle ear in a reverse direction. So when babies are fed while they are sleeping, you can have tracking of either milk feed into the middle ear through the eustachian tube. And because milk is a good culture medium, organisms that colonize this area might as well invade and cause otitis media. With acute sinusitis and otitis media, the common pathogenic bacteria responsible for these conditions include Streptococcus pneumoniae, which is about the most common agent implicated in this condition. Then we have Imophilus Influenzae. Now, it's usually the non-encapsulated variant. So we refer to them as the non-typable because they don't have a capsule. Remember that with the encapsulated strain of this organism, we can use the capsule to type them from A to F. But when they are not encapsulated, we cannot type them. And these are the forms that are less invasive. So they tend to cause mucosal infection, particularly infections of the sinuses and the middle ear. We also have Moraxella catarrhalis, and in neonates, Escherichia coli is particularly important. Chronic sinusitis or chronic otitis media, that is a condition that's existing for more than 12 weeks. Bacterial agents that are implicated, like I told you at the beginning of the discussion, are quite different from those associated with acute presentation. Here you have a more distorted and complex situation. You now have organisms that are opportunistic, such as aerobic gram-negative bacilli like Pseudomonas or Acinetobacter. And you have members of the Enterobacteriaceae, which are essentially facultative anaerobic gram-negative bacilli. Agents such as Klebsiella pneumoniae, Proteus mirabilis, Enterobacter, and Escherichia coli are important in chronic or sinusitis or otitis media. Now, depending on the patient's history, organisms such as Staph aureus and anaerobe may be implicated, particularly when you have some form of intervention before the condition arose. For example, maybe the patient went for an ENT procedure and later came down with infection. In that case, you may be dealing with hospital-acquired pathogens such as Staph aureus. Fungal agents such as Rhizopus species can also give rise to this condition. Otitis externa, which means involvement of the external ear and the auditory canal, as opposed to otitis media, which is middle ear infection. Otitis externa is different from otitis media, not only because of the location, but because it's not a single condition. It's actually a collection of diseases that involve the external auditory meatus and its associated structures. The condition results from a combination of heat, where you have moist heat, desquamation, and maceration of the epithelium of the outer ear canal. Now, maceration means you have softening and breaking down of the skin that results from prolonged exposure to moisture. With otitis externa, the most common pathogenic bacteria responsible include Pseudomonas Aeruginosa, and these tend to give the acute diffuse clinical presentation, particularly in patients with diabetes mellitus. Staph epidermidis and Staph aureus are also important agents. Staph aureus tend to cause an acute localized infection. So you tend to have the purulent lesions localized. Candida albicans is another agent, microbial agent, that could give rise to this condition. Again, in patients with diabetes mellitus or patients who are immune compromised for some other reasons. So this table is just to give us a list of agents that are quite important in these conditions, the associated infection that they cause, and some important comments to note about these agents. Streptococcus pneumoniae, like I said, is the leading agent of acute otitis media and acute sinusitis. And infection can be established by this organism in all age groups. So in children and in adults, strep pneumo is an important agent to keep in mind. Imophilus Influenzae, the non-encapsulated forms. Remember, I said the non-encapsulated ones are also referred to as non-typable, and they tend to cause infections that are associated with. I'll answer your questions at the end of the discussion. So these are associated with mucosal surfaces infection. They are not invasive. They do not cause things like meningitis and sepsis. These agents are implicated in acute otitis media and acute sinusitis, and they come right after strep pneumo as a frequent cause of these conditions. Moraxella catarrhalis can also cause acute otitis media and acute sinusitis, but they are less frequent agents of infection. Strep pyogenes, which is a group A streptococcus, can cause pharyngitis, it can cause otitis media, and it can cause sinusitis, acute presentation. Remember that this is the most important bacterial agent to screen for and treat in cases of bacterial pharyngitis. I think I mentioned this yesterday, that this is the most important strep species. Can cause chronic otitis media and sinusitis, but it's a less frequent agent of infection. And the reason is because, like I said, there must have been some form of intervention that resulted in infection. Now, other agents such as anaerobes and gram-negative bacilli such as E. coli, Klebsiella, and Pseudomonas can result in chronic otitis media, chronic sinusitis, and with Pseudomonas, you can also have otitis externa, the diffuse type. These are usually regarded as opportunistic agents when they cause infections. How do you investigate a patient with these conditions? With otitis media, since the infective process is going on in the middle ear, you should obtain a sample of middle ear fluid during a tympanocentesis, so the ENT doctor should be able to collect the sample and send to the lab. Or you can obtain this middle ear fluid by inserting a tympanostomy tube and collecting the sample. Send for culture for both aerobic and anaerobic, depending on how the patient presented. If you're thinking of acute otitis media, we are going to go ahead and perform aerobic culture. If you have a chronic situation, then it's important to note if anaerobes are also playing a role in that infective process. And of course, we perform susceptibility testing on isolates recovered. One thing I want you to note, if you don't remember anything from this lecture, is, you must not forget this, ear swab obtained from the external auditory canal is not acceptable for investigating a patient with otitis media. I'll go over that again. Ear swab taken from the external auditory canal is not acceptable because what you're doing essentially is getting the normal microbiota in the external auditory tube and sending it to the lab. This is not the organism responsible for the patient's condition. The organism is right there in the middle ear. So do not collect external auditory ear swab and send it to the lab for investigation. It should be rejected. If you have a patient with acute or chronic sinusitis, if you can obtain a sinus aspirate, that would be an ideal sample. If you are unable to get an aspirate, a biopsy material that is put in an appropriate sterile transport medium will be acceptable. If you collect a biopsy material, please remember, do not put it in a dry, sterile container. Remember, the organisms are living things. They require moisture and a medium to support their viability. So if you collect a biopsy specimen, put it in an appropriate transport medium and send the sample to the lab. If you are sending the sample to microbiology lab, please do not put the biopsy specimen in formalin. Formalin will kill the organism and the microbiology laboratory will not be able to do anything with the biopsy specimen. If you're going to send a biopsy specimen to the histology, then you can put it in formalin. But if it is coming to microbiology, please put it in an appropriate transport medium. So let's focus on some of these bacterial agents we have listed in terms of their laboratory characteristics. We start with strep pneumo because this is the most prevalent agent associated with infection. The organism is encapsulated and has a lanceolate shape when we look at it under gram stain. It's also gram positive and they are cocci. They can be arranged in pairs or in short chains as seen on gram stain. I'm sure you still recall all these from your POD lectures. They are catalase negative. This is very important. It helps us to differentiate them from Staph aureus or Staph species generally. The organism is fastidious in that it requires a CO2 enriched environment for isolation. They tend to be alpha hemolytic on blood agar. And like I mentioned yesterday, for the A student, if you want to talk about the selective medium for strep, pyogenes, strep pneumo, crystal violet blood agar is appropriate. But if you say blood agar, you are still correct. Strep pneumo is sensitive to optochin and it is lysed by bile salts, so it's bile salt soluble. Now, the virulence that are important in causing otitis media or sinusitis include the adhesions. Remember that before the infective process can start, the organism should be able to colonize the surface. So these adhesive molecules helps to promote colonization. Then you have production of exotoxins, particularly pneumoniae, which inhibits bactericidal activity of phagocytic cells and contributes to loss of ciliary motility, particularly in the sinuses. It activates the classic complement pathway and it results in inflammation. With inflammation, you're going to have occlusion of the drainage passages. Then the presence of polysaccharide capsules prevents phagocytosis. Another feature of strep pneumo is phase variation, which is important in invasive disease. Imophilus influenzae is also an important agent of infection. These are tiny, pleomorphic, gram-negative bacilli. Because they are very short rods, we refer to them as cocobacilli. They are oxidase positive and they are facultative anaerobes. Again, this is another fastidious organism that requires peculiar growth conditions and agents. With Haemophilus influenzae, factor X and V are required for isolation in the medium. Growth is also enhanced under CO2 enriched environment. Like I've stated earlier, you can have capsulated and non-encapsulated strains of the organism. With sinusitis and otitis media, the non-encapsulated strains are more important. With invasive diseases, the encapsulated forms are important. The organism exhibits what we call satellitism on blood agar containing a Staph aureus streak. I think we've discussed this before when we had the neuro lab, but just as a quick reminder, most strains of Haemophilus influenzae do not grow on blood agar, okay, unless it contains these additional factors. So Staph aureus streak, which is hemolytic, it must be a hemolytic strain of Staph aureus, is also inoculated onto the blood agar plate. So the Staph aureus will produce the NAD as a metabolic byproduct. Therefore, the Haemophilus influenza may grow on blood agar in very close proximity to the colonies of Staph aureus, okay? The virulence factors associated with this organism that helps it to establish an infective process at this site include outer membrane proteins such as Pili and high molecular weight factors 1 and 2. Again, these are adhesive factors, more or less. They help in the colonization of the oropharynx. And like I said, that's the first step towards the infection. The organism is also a producer of immunoglobulin A proteases. Remember that immunoglobulin A offers protective function on mucosal surfaces. When this immunoglobulin is cleaved, it enhances the colonization ability of these microbes. So they have a higher propensity to colonize the mucosal surfaces after destroying the immunoglobulin A. In encapsulated strains, the capsules will prevent phagocytosis. So this is not important in causing otitis media, but when we think of meningitis, when we think of sepsis, the capsule is an important virulence factor. Now, the less frequent agent of acute otitis media or sinusitis is Moraxella catarrhalis. It is a strict human pathogen that is found in the upper respiratory tract, and colonization is age-dependent, with children being relatively more colonized than adults. They are gram-negative diplococci with flattened adjacent sites, and this can cause confusion in the lab because they look very similar to Neisseria species. And we can have non-pathogenic Neisseria species colonizing the oropharynx. So it's very important when we have this isolate in the laboratory, it is very important for the clinical team to relate this isolate to the clinical presentation of the patient, because this is not a frequent cause of otitis media or sinusitis. So you really have to look at the patient's history and make up your mind if this is a significant finding. These organisms are oxidase, catalase, and DNase positive. You remember what all this means. The DNase test helps to differentiate them from Neisseria species, which are DNase negative, and they grow as round opaque colonies on blood agar and chocolate agar. So here you have a blood agar plate showing the growth of this organism. The virulence factors associated with these organisms include its ability to form a biofilm. When an organism is within the biofilm, it is resistant to the clearing mechanisms and to the effect of antibiotics. So the immune system cannot get to the organism while it is within a biofilm. These organisms also exhibit complement resistance, and you have production of different types of adhesions. At the time, you have some form of immune response to a prevalent adhesion that the organism has elaborated. It's going to switch to something else. So the immune system is continuously being fooled. Then the organism is able to induce inflammation. Remember that with inflammation, you're going to have obstruction to the drainage of body fluid. Anywhere where you have collection of body fluid, it's a good culture medium for microbes. Staphylococcus aureus, like I said, could be an agent in chronic or otitis media or sinusitis, particularly where in which the patient had a form of procedure in the past. Staph aureus are gram-positive foci that tend to appear in clusters. They are catalase, coagulase, and DNase positive. They are commonly seen in chronic otitis media and in patients with inserted tympanostomy tubes. Virulence factors associated with this organism includes the surface proteins which promote colonization, production of invasins, things like glucosidins, kinases, and hyaluronidases. These can promote the spread of organism in tissues so they can digest their way through tissue planes. Protein A is also important because it prevents phagocytosis by binding to the Fc portion of immunoglobulin G. Production of exotoxins can also occur in some strains of Staph aureus, and this can damage the host cell. With the damage to the host cells, there is some form of inflammatory response, and you have occlusion of the drainage passages. Pseudomonas Aeruginosa is important in patients with underlying medical conditions. Patients with cystic fibrosis, patients with diabetes mellitus, or patients who have some form of immunocompromised state, maybe as a form of therapy, for example, steroid therapy, or patients on chemotherapy for whatever reason. Pseudomonas is an opportunistic, strictly aerobic, gram-negative bacillus. It is motile, and it does not form spores. The organism is catalase positive and it's oxidase positive as well. This is a revision of your POD. We know that some strains of this organism produce diffusible pigments, which we can use in the laboratory to make a presumptive identification. Virulence factors associated with this organism include production of exotoxins. There are different types of exotoxins. Its ability to produce degradative enzymes like elastase, alkaline proteases, and phospholipase C, which are all components of the host tissue and cells. Then we have the presence of pili, and flagellum. Pili will enhance colonization. Flagellum will enable the organism to move rapidly from one site to the other. And being a gram-negative, lipopolysaccharide is also a virulence factor. That's the endotoxin. Now, I'm not going to go into details as to specific antibiotic agents that you can use to treat infection, because I believe you're going to have that lecture with the pharmacology department. However, when antibiotics are indicated, there are some guidelines as to why you're going to use a particular agent. And this usually includes the clinical and microbiological efficacy of the agents you plan to use. Will the agent penetrate into the middle ear in a high enough concentration to achieve cure? Then you also have to consider the patient population you're dealing with, the absence of side effects and toxicity. For example, if you have a patient with pre-existing renal compromise, you have to make sure that the agents you're going to use to treat the infection will not compromise the renal status further. The side effect is also important. If the patient is known to be allergic to the particular agent you want to use, then you have to look for alternatives. You also have to consider the convenience of the dosing schedule. If you have to use an agent that you're going to be administering every 3 hours, it may not promote the patient's drug compliance. But if you have an alternative that the patient has to take just once in a day, the likelihood that the patient will stick to that schedule is going to be higher. And then you have to consider the cost as well. If the patient is not going to be able to afford the entire duration of therapy, then don't start the patient on that particular agent, because you're going to encourage antimicrobial resistance if you start and then you stop before completing the dose. Now, there are complications that could follow these conditions. With acute otitis media, it can progress onto chronic otitis media. You can have perforation of the tympanic membrane. You can have a spread to adjacent sites. So you can have mastocytitis. With treatment of acute otitis media, the patient may have some degree of hearing loss. You can also have spread of the infective process to involve the meninges and the brain. You can have labyrinthitis or facial nerve palsy, depending on how terrible the situation was with the patient. With sinusitis, you can also have contiguous spread, so the patient may end up with meningitis. There could be intracranial abscess. There could be subdural empyema. You may have osteomyelitis of the bones of the face, or it could result in chronic sinusitis. So we've discussed the most common microbial agents of sinus infections, bacterial agents, but you should note that bacterial agents are just responsible for about a quarter of infections. Most infections are due to viruses. And like I said, it's very difficult to differentiate between the two on clinical grounds. When we have bacterial agents, these three organisms are the top organisms on the list. The epidemiology of bacterial agents also change under chronic conditions. That's when we have other agents such as the anaerobes, such as the facultative, gram-negative, Enterobacteriaceae, and other agents such as Staph aureus being important in this case. You should note that Pseudomonas aeruginosa is an important opportunistic agent in immune-compromised hosts. So when you have a patient who has predisposing factors, underlying predisposing factors that could result in an immune-compromised state, you should think of Pseudomonas aeruginosa. You should also note that the air cell collected from a non-discharging ear is not acceptable for microbiological investigation. Always aim to send in the aspirate from the middle ear, either collected through an aspiration needle or through a tympanostomy tube to the laboratory for investigation. So, any questions? Let me start with the chat. Then, because I think there's somebody who raised up her hand, I'll come back to that person. Is there any sound? Okay. Okay, for strep pneumoniae, what does the bile salt test mean? Oh, it's one of the laboratory features that we use to characterize strep pneumoniae. Strep pneumoniae is lysed in the presence of bile salts, whereas other alpha hemolytic strep species, such as the viridans strep, they are resistant to bile salt dissolution. So it's a laboratory characteristic of this organism, and it's important. Oh, what do I mean by virulence factors? Virulence factors, my goodness, you did this in PhD, didn't you? Virulence factors are those components associated with the organism that makes it a successful pathogen. Things associated with the organism that can make it evade the immune system, that can make it readily establish itself as a pathogen in the host. These are regarded as virulence factors. So things like a capsule is a virulence factor because it's going to prevent phagocytosis. Encapsulated organisms are difficult to phagocytose. Things like Pili are regarded as virulence factors because they promote colonization. Colonization means that the organism is able to attach itself to the mucosal surface and then start replicating. So if they are able to get a foothold, that's a virulence factor. Okay? So there are other virulence factors, you know, toxin production and things like that. So you're welcome. Now, somebody raised her hand. Please, can you go ahead and ask your question? Somebody raised their hand. Please, can you go ahead? Ask your question, unmute yourself and ask your question, please. Okay, it might have been a mistake. Okay. So any other question? Okay, so have a good day.